All right, well, thank you very much for the invitation. I can see very nicely how the organizers, this follows beautifully on what we talked about in the first two sessions. Begin by a little bit of an introduction to the eMERGE project. It's been through three phases. The phase one began in 2007. And the concept at the time was, could we demonstrate that there was actually utility in data mining of electronic health records linked to participants in biobanks to actually do discovery and primarily discovery research in the area of genomics. It seems funny to say, but in 2007, I think there were a lot of skeptics about whether that was even a possibility. And the good news is that in the course of eMERGE 1, we were able to demonstrate, in fact, that electronic health records are a perfectly reasonable way, if used properly, big caveat, but if used properly, to actually develop cohorts that could be used to do gene association studies and other kinds of genomics research. That having been established, eMERGE 2 began in 2011 and ran to 2015. Expanded the numbers of phenotypes and focused on electronic algorithm generation, and began the process of implementation research. How do we actually use that information from electronic health records, from GWAS studies, and from other kinds of genotype information to actually begin to implement the genomic medicine and how to think about putting some of that information back in electronic health records and use that to improve patient care and outcomes. eMERGE 3 began in 2015, specifically with the concept of now moving forward to sequencing, to deploy that evidence, to generate more evidence, and then to deploy that information in electronic health records in a way that it could be returned to them through the electronic health records information, and then to understand what the consequences for patients, families, and providers are in terms of returning that result. We're using a 109 gene panel, which includes, I should say, all of the 59 ACMG secondary findings, recommendations for returning results if there are secondary findings. And across the network, we have a range of approaches in which some people are using indication-based sequencing for their genes, and I would say probably about a half or so of the sites are using non-indication-based sequencing, so it gives us a nice range of ways to think about it. It now consists of over 10 clinical sites with a cohort of 125,000 genotype samples linked to detailed phenotype information from electronic health records. So with that as background, I thought I would just make points in a couple of areas that we can then expand on during the discussion period. The first, which was discussed a lot in the last session, was the concept of CLIA versus non CLIA results. And I'll just give one example that may be illustrative. It's an example, not a statistically significant sample, so I should say that at the beginning. But in the course of our study of the eMERGE PGX project, where we sequenced the 84 genes that were relevant to drug metabolism, and then with the purpose of returning the results, so once we got a result that we deemed returnable, then that result was validated in a CLIA laboratory and then put into electronic health records. Interestingly, our experience was that we had several cases of discordance between the sequence, and I should say in this panel, our sequence was about 500-fold coverage over each of the bases of the genes that we sequenced, and some of the CLIA results that we got. And interestingly, some of those represented sample swaps, as we've heard about, but some of them actually represented true discordance. And in all cases where the discordance was resolved, the deep sequence was actually the correct data, the correct result, not the CLIA sample, or CLIA result. So to the point that several people have already made, just the fact that it's a CLIA sample does not mean the result is correct, and just the fact that it's not a CLIA sample does not mean that the result is incorrect. So I think that's important. The other point is not only the quality of the assay, but the question of chain of custody. And I think one of the things that we've talked about is the fact that since many of the sites involved in eMERGE are sites that are pretty large-scale genomic sites and are involved in a lot of these kinds of studies, We may be labs that fit at one end of that spectrum of how well we do things, we'd like to think at least. But I think one of the factors is many of the labs are highly automated in terms of what they do. So that may be affecting the chain of custody. The second point I wanted to make was related to the integration of data into electronic health records. As many of you know, the current report of choice by most reporting laboratories is a PDF. PDFs are not so useful if what you want to do is integrate into electronic health records and use that to fire clinical decision support. I'm happy to talk more about that. There's also issues related to the timing of the release, because in some cases, the release of the report into the result means it's also immediately visible to the participant. The perspectives of participants has generally been very, very positive, I would say. In fact, in eMERGE 3, we didn't even have to do much to achieve our recruitment targets. People were literally calling us to say that they wanted to participate because they knew they were going to get genetic results in return. To one point that was made earlier, these are typically people that are seen in a healthcare system, so they're not so worried about getting a subsequent follow-up if needed. But I will add that in the days when the ACA repeal was very actively under discussion in Congress, our recruitment slowed, and we actually had people cancel their appointments to be participants because of their concern that they might actually lose their coverage. Fortunately, that's now gone back to normal. And then finally, perspectives of the treating physicians, and I think you heard very clearly in the previous session, and I would just amplify that very much, that in fact, we got a lot of pushback from our physicians in terms of having to take on the task of discussing with the participants. And as a consequence of that, in eMERGE 2, where the primary care physicians were the primary people responsible for returning results, in eMERGE 3, we've moved on to train genetic counselors to provide those results back.
Great.